Hi, everyone. Thank you for joining the Endo Education Project today. We're here with Dr. Ginger Gardner. We have a loaded conversation regarding the hidden connections between pelvic floor, hip pain, and endometriosis. So thank you, Dr. Gardner, for joining us. If you want to say hi and give a little bit of your background.
Well, thanks for inviting me, Nicole. This is one of my favorite things to talk about. It's the thing I'm most passionate about. A little bit about my background. I am, going on nearly 30 years in physical therapy. I also have a background in sports medicine. And the way those two ended up being fused to kind of bring me to where I am today is that starting out in orthopedics, you get a really good, solid grounding of the body and physiology and everything that actually lends itself well to treating pelvic pain and pelvic health issues. Because I feel like in order to have a deeper understanding of when someone might come in and present with different things, which I think we'll end up getting to, a little later, like what if they have hip pain? You need to be able to kind of screen through all of those things. And so starting out in ortho was kind of a natural evolution to then progress and add pelvic health as a specialty. And then as I began to appreciate more about, I teach continuing education. And so in order to teach, you need to continuously learn. And in looking at all of the really specific ways in which the pelvic floor is connected to other things like the voice, the respiratory diaphragm, the jaw, things that we think are unrelated are very much related. That is kind of like, opening a Pandora's box, if you will, in a positive way of then appreciating, oh gosh, well, hormones matter to your voice. Like when someone's voice, when a boy's voice changes, as they go through puberty or whatnot, and you think about how across a lifespan that may impact women's voices too. Then it all comes together and you go, oh my gosh, orthopedics matter and pelvic health matters, and then hormones matter to the pelvic floor, and outcomes and all those things, and so in the nearly 3-decade evolution of practice, that's kind of where I've ended up where I am today. That's the short story.
Yeah, I love that your work it's highlighted some of the most fascinating connections that many patients and even clinicians are not aware of. So I guess we'll start with the one that might be the most surprising to some listeners is the importance of pelvic floor rehabilitation in endometriosis care. So can you help us understand a little bit more about that connection and why it's so overlooked often in traditional therapies?
Yeah, I think first off, the reason that the pelvic floor and really pelvic health, because it's a whole entity in itself and not just the pelvic floor,
Yeah.
is often overlooked is because endometriosis is often overlooked and missed. And women get medically gaslit all the time. I think their pain is ignored. Um, they are often ignored. Their symptoms are ignored and passed off as just being a woman because periods should hurt, which we know isn't true. And so when you look at that and you also take a step and look back at other aspects of care for women's health, prenatal postpartum, for example, um, we get 1 6-week appointment postpartum, and you're just supposed to put everything back together like on your own and figure it out
Oh,
after a 9-10 month race or marathon, as I like to call it, of giving birth. And so that aspect is overlooked. Women's healthcare in general is overlooked. And yes, everyone has a pelvis and everyone has a pelvic floor. So you can find similar areas in men's health and other gender health related concerns that if it has anything to do with pelvic health, it's going to be overlooked. And I think that's why it happens in endometriosis is if someone even does get that diagnosis when they do, which is often like a 10-year delay of them getting a diagnosis, how do we think their pelvic floor and their pelvic girdle and everything, the low back, everything that goes with it, is going to present after that amount of time? And the case usually is when someone gets to my office and sits down, they A, had a very, very delayed diagnosis, and then B, they were never really appropriately referred for pelvic floor therapy and pelvic health in general. So I think we have three underserved areas that converge to make kind of a perfect storm. We have women's health underserved, we have pelvic health underserved and under, attended to, and we have endometriosis as definitely an under attended to issue.
How does the impact of chronic stress patterns connect to pelvic health?
Yeah, that's a great question, Nicole. I think the easiest way to relate to how important the pelvic floor is in just whole health, whole systems, body health, and stress is if you think about when someone is experiencing something traumatic or sad, um, something painful, something hurtful, they may be crying, they may be emotional, but they're also going to do a specific, kind of nucleus of other things. They might drop their head, which then shortens the front of the muscles in the neck. It makes it harder to voice. Some people lose their voice when they get into those stressful patterns. Um, their breathing becomes altered. They may have breathing dysfunction. They may not realize. They go into kind of a holding pattern, kind of a fetal position, if you will. It may not be the full blown curl up in a ball in the middle of the floor. When someone has trauma, repeated stress, but that is, figuratively and sometimes literally what happens. It shortens the hip flexor, it shortens the pelvic floor. And then over time, the pelvic floor is going to be one of the first things, if not the voice also, and the diaphragm, breathing. But those three diaphragms together, the voice, the vocal diaphragm, the respiratory diaphragm, and the pelvic diaphragm all together are going to be negatively impacted from chronic stress. And if you think about the experience of a person going in, usually women, going in to confide in their healthcare provider about pain that could very well be endometriosis, and they're dismissed. They have stress inside the system that they're going to, that's supposed to be a safe sanctuary to share their concerns and problems and feelings, is being ignored. So then they have the stress and the kind of the betrayal inside the system of healthcare. But then they're also experiencing pain and stress related to that. And then the emotional burden and stress of, looking for help and maybe family members not understanding. It's no wonder that the pelvic floor suffers so much adversely from the impacts of stress.
Is that then how breath coordination and diaphragmatic function can then have a positive impact on pelvic health?
Yeah, that's a great question. One of the most profound ways that I see that as a clinician, and then the way that I convey that to my patients, is using musculoskeletal ultrasound imaging. So I'll do a transabdominal image just, through the abdominal wall. And sometimes I'll actually image the respiratory diaphragm as well. But as I'm imaging those in real time in the clinic, my patients can see how their breathing impacts their pelvic floor, because I'll be looking at their pelvic floor while they're actually breathing. And I'll take them through a series of activities and exercises and say, even talking about their stressful problems. And then they can see in real time how their pelvic floor is literally reacting. But on the flip side, the positive side is that as I'm changing their breathing techniques and teaching them how to breathe better, they can actually not only see it on the screen, but then feel it in their bodies. And I think that's probably the most profound, important piece of the puzzle is if they can match up what they are feeling inside to what they are doing outside, whether it's just breathing, right? Walking, whatever what is they're doing, then the pain they're experiencing also becomes less scary, because my job is to then teach them, oh, I had that pain when I was breathing here. That's not a bad thing. If I'll actually do this breathing technique for this amount of time, that muscle or whatever it is that, was a little hyper and not relaxing can then go on to relax just like they saw it on the screen, when they were in session.
That's really fascinating. I didn't know you did ultrasounds on like that. That's really
Yeah.
fascinating.
Yeah.
That you like as
It's
someone's breathing.
it's so important to, and what we'll start doing is just I'll have them breathe and I won't change anything about what they're doing. And then I'll point out all the little pieces of, do you see that hip muscle? Do you see that, the pelvic floor? Do you see how it's even impacting the bladder? Because as you know, it's not just pelvic floor pain, the diaphragm, it's also the bladder, and you can have bladder pain, interstitial cystitis, that kind of thing. So we look at how their breathing impacts the bladder as well.
Can you share more about how there's, in your findings, a woman with endometriosis, anything unique that's common, like when you're doing those ultrasounds that you commonly find with those who've been diagnosed with endometriosis or suspected endometriosis?
Yeah, there is actually. And it's why I'm a huge proponent of every single patient who has endometriosis, whether or not they have excision, and especially when they have excision, that 100% of them are referred to pelvic health after. They should use, they should have rather a couple of visits ahead of time to prepare them for surgery and what happens. But, if they're having ongoing pain, teaching them pain management techniques is pretty critical before they go into surgery. And if they've had excision surgery, it's to work through all the postoperative pieces of the puzzle that you have. It's pretty much requisite. But when someone comes in and they have endo, or I suspect that they have endo, they do present with a kind of a, I don't want to say typical or classical pattern, because if you've seen one person with endo, you've seen one person with endo, and I'd like to treat everyone individually. But you do see patterns arise over time. And one of the most common ones is because endometriosis, as you know, is not a reproductive organ disease. It's a whole systems body experience and disease, and it can particularly impact the digestive system. So they don't just come in with pelvic floor pain, they come in with stomach pain. They are, they have difficulty with eating, or they may actually restrict their eating or severely restrict their eating because they don't know what they can eat that's not going to cause pain. One of the things that I will commonly see is they start to breathe more shallow, that they will chest breathe or do what I call mask breathing, which is where you'll see some of the muscles in the neck actually stand out when they're trying to breathe. Or they will paradoxical and shallow breathe, wherein they'll just barely lift the chest when they breathe, and then the belly will actually pull in as they inhale, rather than the belly going out when they inhale. And that creates chronic pelvic floor tension and shortens the pelvic floor. So one of the things that I will see, and I use imaging, and I use imaging for this as well. And I think a big plus for using that in the clinic is because it's non-invasive. I don't necessarily have to do an internal exam, which can be really painful if you already have pain, right? And you've already been traumatized inside the system with being checked out so many times and no one ever being able to help, or someone causing pain. This is a perfect solution because it's non-invasive. And then I can image through their abdominal wall to look at a couple of things. One, is the respiratory diaphragm actually moving as much as it should? And one of the most common things is that people will lose their ability to what if you hold your hands up in like a C around your rib cage, you should have what's called lateral costal breathing. So when you inhale, the rib cage should come out and get bigger, but not really flare in the front. So the front of the rib cage shouldn't really flare up, kind of like a car hood lifting.
Yeah.
It should really more flare like a bucket handle lifting out to the side. And if it doesn't, and they've been in pain for a while, I will see just very little excursion through the respiratory diaphragm. So the diaphragm is just not moving as much, and the rib cage doesn't move as much, and they get more into a splinted pattern of breathing. That also shortens the abdominal wall. And then when that happens, a couple of things can present then. You can get myofascial restriction, which sometimes can lend itself to nerve issues in the abdominal wall, which can show up in the pelvic floor and down the legs, and in and through the abdominal wall as well. In addition to just myofascial restriction, or sometimes you'll see the abdominal wall different layers of the abdominal muscles in the abdominal wall will be overactive versus compared to other muscles in the abdominal wall. And that's impactful because the certain layers of the abdominal wall actually feed forward in the same fascial plane as the pelvic floor. So if someone's coming in with obvious pelvic pain, with endo, with bloating and GI issues, the whole abdominal wall has to be, extensively evaluated. And so you'll see too much, just as a review, you'll see too much through the abdominal wall, too much muscle tension, fascial tension, neural tension. You'll see not enough movement through the respiratory diaphragm. We typically want at least 20, I prefer 40, millimeters of excursion. So in the diaphragm, and you won't see really anything. And then you won't see very much movement in the pelvic floor. So when I ask them to take an inhale, they should have a bucket handle breath. The pelvic floor should drop, with the respiratory diaphragm. They move together, but you won't see that. I will see a pelvic floor that's just kind of tight and not moving at all when they breathe, just maybe a few millimeters. And we want several millimeters of movement. So that's just some of the things that I will see on clinical examination when someone comes in. And those are pretty typical.
Do you see that that could be better or worse after surgery, considering all the scar tissue and trauma to the
Gosh,
body?
yeah, you're asking great questions. Yes, and yes. Yes, because of the trauma of the surgery. I think what's not in kind of the memo or the brochure, for surgery is yes, excision is the gold standard. However, you do end up with surgical deficits, or what I like to call surgical deficits as well. So you have this list, you have this bucket of things or list that are wrong before you go in.
Yeah.
And it's a lot of it's related to pain and gastrointestinal discomfort and systemic inflammation and hormonal dysregulation and a whole bunch of stuff. That's in this bucket. And if I can see them before surgery, and usually I do because people come in suspecting they have endo, and I'll screen and then send them on to surgery, but continue to see them, we will work through that bucket of stuff so that they have less pain and they have a higher quality of life. But then you have the second bucket, you have the surgical bucket or list, and you have a whole lot of things that happen just as a result of you having had surgery. Scarring that you mentioned is a big one. And we want to make sure we work through, you usually have 3 incisions. We want to make sure we work through all of the scar mobilization, which then turns into also visceral mobilization. Because a lot of times, if you think about the somatic response of the body, what would happen again if they go into that chronic stress, that fight, flight, freeze? What happens to the gastrointestinal system also? Well, it has to choose, right? It goes into that same response of, it can be even a freeze response where you don't even get as much gastric movement, and there can be kind of a gastroparesis, if you will, of the intestines just not moving as they should. And then after you go through the trauma of surgery and the gas distension and everything that happens, you still are going to have slow motility. And so if you can get in there and gently do visceral mobilizations, that's also one thing that you can help, which feels unrelated to the pelvic floor, but it's the same fascial plane. So if I'm treating visceral motility, gastrointestinal motility, I'm also treating some of the things that would feed forward into, the more practical, what we think of are the obvious things for pelvic therapy, like your hip flexors, right? You're going to spend more time in bed, maybe seated. You're trying to heal. Things hurt. You're holding the pillow under your stomach. It hurts to cough, that kind of thing. Your hip flexors are going to get tight. And they can also be cut through at the same time, or, dissected back, not really cut through, but dissected back. Those hip flexors often respond with kind of their own stress response of going, oh my gosh, kind of tightening up and shortening. And that is not helping the rest of the body either. So that's another way that, we'll work through post-op some of the surgical bucket issues in addition to just the general, endometriosis treatment.
I'm happy you brought up hip pain because that's the next part I wanted to talk about.
Good segue.
For that, just while we're talking about excision surgery, for those who don't have your insurance or don't have insurance at all and can't afford to go maybe once a week or consistently, what would be the I mean, I know I'm sure it's different for each patient, but like generally speaking, the recommended time frame that you're like, you definitely need to prioritize getting to pelvic floor therapy this many weeks after surgery, this many weeks before.
Right. Well, I have a whole kind of protocol, if you will, that I'll go through when people are facing, excision surgery. And that usually takes me 1 session to go through. So they, at least if they can't get in for regular therapy to work on pain management, which is pretty critical, then I'll say, okay, let's just do one. We'll do one prehab visit to get you ready for surgery, because I have a whole laundry list of things that I go through on everything from bowel prep to what they want to pack, how they're going to manage pain in the hospital, how they're going to move that the gas that they distend the stomach with, how they're going to move that through the system quicker, what to do when pain arises so that they're not afraid and they get into that, again, that fight, flight, freeze, where they may be holding muscles, because holding muscle tension hurts so much more than knowing how to let it go. So we'll go through all of that in a single session, which is about an hour. If there are other things that are outstanding, it could be hormone issues, it could be systemic inflammation. Those are things that we can measure ahead of time and say, okay, for the most optimal surgical outcome, we need to go ahead and control inflammation. How is your sleep? How is your diet? Can we identify any nutritional triggers? How's your stress management? What happens when you're in pain? And we work through that piece. How much physical activity are you able to get? And then I customize that to be able to fit their situation, because not everyone's going to even feel like doing that, prior to surgery. And then of course, post-op too. And then environmental contributors, like could be literal social support, and finding a network that they can plug into, making sure that before surgery, there's meal prep and things like that done, because they're going to want a particular diet after, especially if we've done our work beforehand and they know what the nutritional triggers are. If someone sets up a meal train for them or whatever, they can put that stuff on the list. So I try to be very practical about helping people through that surgical time. And then we go back. That helps to control inflammation. It also helps to control environmental other issues like xenoestrogens, for example, fake estrogens. They are in shampoo, soap, food, household cleaners, all kinds of self-care products that we wouldn't think about. And because endometriosis creates its own estrogen, which is not a good thing, we don't need any more environmental estrogen, added, whether it's added hormones into the food you're sourcing, like meat, poultry, that kind of thing, is pulling all that out and make sure that the diet's pretty clean, that you pull all that stuff out of your household cleaners and self-care products, so that you're not adding insult to injury by adding more fake estrogens into, your everyday life.
Yeah.
So that's kind of what, like, a nutshell of what it looks like before. After is a whole different kind of can of worms, because since excision is the gold standard, we often don't know how invasive it is and where it has traveled to or
Yeah.
grown. And adhesions, how they scarred before, if they had an ablation, which, as we know, is not the gold standard. It can be even messier and they end up doing more work. So you can be in therapy a lot longer after. But in terms of when you can be seen after excision, it's pretty much as soon as you feel good enough to sit up and talk to me or your therapist via Zoom, like a telehealth session. It could be 30 minutes, it could be an hour, but you're going to have pain that maybe wasn't addressed in my pre-op, protocol. And I want to make sure that people know how to manage that pain. It also cuts down on them having to, call the surgeon back. If I can say, that pain's your hip flexor. We can work through that. You don't need to take pain meds for that. And then, prolong how long you're on opioids, which gives you a whole other, issue of digestive woes and that kind of thing. So it helps them wean from their medication sooner, feel more confident about the pain they are experiencing, that they can handle that and manage it, and they have the tools to do it. And then later on, usually 6 weeks or so down the line, we'll then start in earnest what people think of as post-op therapy. That means looking at the pelvic floor, et cetera. But when you're using imaging, when you're doing integrative physical therapy, you can start PT and should start therapy right away after excision surgery.
That's a good timeline. That's a good one, because I feel like that's the $1 million question is like, okay, now when do I just had surgery, spent a lot of money on it, and now how much should I go to pelvic floor therapy? How often? When should I start? Yeah, thank you for explaining that whole timeline. And then
Yeah.
just going back to the hip pain,
Mhm.
how can hip pain mask or mimic endometriosis symptoms?
That is a $1 million question. I've had so many patients with that issue. And to kind of tie up, put a ribbon around the post-op, when should you start pelvic floor and pelvic health therapy? I think the most common misconception there is that you got to wait 6 weeks to start. And I know a lot of surgeons say that, wait 6 weeks and then don't start until then. 6 weeks is a long time to wait to start the therapy that would help you address, for example, the hip pain, the very next thing we're going to talk about. Because if you've existed with that level of pain, that is not going to just suddenly go away. And then you're waiting 6 more weeks before you could, address it. There are so many things that can be addressed immediately post-op that I tell my patients, have your caregiver, whoever's with you, log into the portal. And as soon as you feel good enough to tell them how you're doing, please send me a note in the patient portal to let me know how you're doing. If you've got any kind of unexpected pain, I can help you manage it on the spot. You don't have to wait. And so I just wanted to say that because I think too many patients are getting oh, you may not need it after excision, your surgery, all your pain may go away. That's not a good answer. Everyone needs to have PT or OT, but I will say this, when it comes to OT, unless they're very, very steeped in orthopedics, it's difficult for a pelvic OT to have the depth of knowledge for orthopedic experience that's needed to actually treat endo. And here's why: because of the hip, because of the thing we're about to go into next. If they've had extensive training in orthopedics and pelvic health as an OT, fantastic. But I think that it's important to, as a therapist, to know your limits. If you're a therapist, you want to specialize in endometriosis, but you do not have an orthopedic background and you've only done pelvic health, know your limits. Don't wait for a patient to, languish under your care because you're just treating the pelvic floor and you haven't considered the hip and the pelvic girdle. And that happens too often. So to answer your question about the hip, let's take like a typical patient that would come in and, have a seat. I will pick from several cases that I have, just so I'm not kind of singling out a single patient. But the other reason I'm going to pick from several cases and kind of combine them is because it's so typical for this to happen. So common that I want to give the listener a very accurate description of what happens when you're trying to differentiate from, is this hip pain or is this endo pain? And that is this. So I have patients come in and they typically do not know they have endo. And they sit down in my chair across from me and they tell me their story. And then I immediately go into endometriosis screening first because it's important. And as you well know too, I mean, early intervention is the best. The earliest they can get excision surgery and get the endo out, the better off they're going to be. And so I'm going to use some examples of the youngest patients that I have had, because what's happening is not okay. And I just want everybody to know about it. I've had more than one, more than two, more than three, and this is in the last few months. Patient come sit down and tell me their story and said they've had multiple hip arthroscopies and no one had ever screened them for endometriosis. And it turns out that their pain was not coming from a hip labral tear or femoral acetabular impingement. It was actually endometriosis. But because no one was screening for it, they went on to have a very expensive and very invasive surgery. Not once, not twice, sometimes up to 5 times. I've had patients come in with hip surgeries, and these are not, 30-year-old, yes, is also young. This is younger than that. I think 20s and younger.
Which doctor performs that surgery?
Orthopedic surgeon.
Orthopedic surgeon.
And are they going to screen for endo?
No.
No, they're not. They're going to look at that patient and they're going to measure they're going to take an x-ray and weight bearing of their hip. And if they see now if it's a good hip preservation specialist, they're also going to measure for hip dysplasia, which is one of the other things that I specialize in as a therapist in orthopedics. And if they see any measure of dysplasia and, hypermobility, and people with endo, they also have hypermobility. And then what does that lend itself to? A hip labral tear or hip impingement, right? They're going to look like a surgical candidate for hip arthroscopy pretty quickly. And if you're in pain and you've been in pain for a long time, you can then see how easy it would be as the patient to go, oh, this is hip. I'm just going to have this massive hip surgery that takes not 4 months like the protocol talks about. It's more like a 12-month cycle, of therapy, of dedicated therapy that you have to go through. So when you're trying to differentiate between a hip labral tear or a hip impingement and endometriosis, oftentimes if you hold them in two hands and you've got the hip on the one side and you got the endo on the other, and which one is it? The first thing I ask is, do you have any gastrointestinal issues? Because generally with hip issues, they're not going to have GI issues. If they also have accompanying cyclical issues, period pain, I'll often talk to them about or ask them about, when is that pain worse? Because sometimes you can have worse hip pain during a cycle that is related to endo, and it can make the hip pain feel worse too. So that gets a little bit fuzzy in terms of attaching pain to a cycle. Because a lot of people will say, oh, painful cycle, got to be endo. Not
Yeah.
necessarily. Not necessarily. It can still be a dedicated hip issue. And I've had that happen. In those cases, we work to control the kind of sequela of symptoms that would create increased hip pain during a cycle, because that can happen and still just be hip pain. So the other thing that I ask them about beyond, gastrointestinal issues is the number one best way to tell if someone has a hip issue, if it's a hip issue versus an endo issue, is with hip issues, they're going to have usually more than 86% of the time, they're going to have popping, clicking, catching, even giving way of the hip, where they will go from sit to stand and it doesn't quite feel right.
Yeah.
Now, if you have endometriosis and the hypermobility kind of spectrum that happens with endo, then you could have mechanical symptoms and still not have a labral tear, but it's more related to the hypermobility aspect that kind of can go with endo sometimes. And I use ultrasound imaging to determine that, to see what's going on inside the hip. Do they have the structural support that they need inside the hip? And I'll also look for dysplasia as well, because it may not be a hip issue. It could just be, if I often will say to patients, if this is my pelvis and this is, femoral head, if you have hypermobility, it might be it's just a little sloppy in there, and we'll work on it muscularly to better support the hip. And that's also another argument for having therapy before and after excision surgery if you have hypermobility, because the hip is the connecting point. And if that doesn't feel good, everything else is off. So I'll work on shoring up that issue of hypermobility in the hip once we measure it and see what's going on. That would mean that they could still, they could have endo without having a labral tear or impingement. They just have the hypermobility aspect of that. So the catching, clicking, popping, and giving way is a pretty big red flag that you could have a hip labral tear and or impingement. And there's screening tests, of course, I'll evaluate patients for. And if those screening tests are positive, I'll usually refer them out to a surgeon so they can get a high resolution MRI or an MRA to see if it can identify a labral tear and impingement. And then we go from there. But those are kind of the highlights of what I will ask patients when they come in initially. Back to the cases that I was just thinking about, when that particular kind of batch lately of patients sat down, they had already been through hip scopes or multiple hip interventions, injections, things that weren't really necessary to put them through without having screened for endo. And because they had a family history, they had not just period pain, but incredibly dysfunctional cycles. They had a lot of gastrointestinal issues and food nutritional triggers and things like that. And none of that had been controlled for. That is then my radar that goes up to go, we do need a surgical consult to see if this is endo or not.
Because of the hypermobility aspect, and are you able to diagnose or refer for EDS?
Yeah,
No?
the new clinical guidelines for that, I believe, correct me if I'm wrong, are going to come out next year. So I'm hoping that we have better diagnostic criteria for that in the future, because right now the only scale that we have, and then there's some clinical signs, which are also kind of vague, like, is your skin stretchy? Well, that's
Yeah.
very vague, right? That's not anything you can definitively put your finger on. And yet some people have hypermobility and EDS, but they don't have that. The only scale that we have, the Baton scale, really is isolated way to measure just a few joints for hypermobility. And you can still have EDS, but not actually qualify via the Baton scale. So we need better parameters around diagnosing generalized hypermobility disorder and EDS for sure. It's not something that we generally would diagnose as a physical therapy diagnosis. Um, and in different states, depending on where you are, we are one of them in North Carolina. It can be very hard to find someone who actually will take it seriously and listen to someone with EDS to give them that diagnosis. But it really does take a village, in that aspect. And I just interviewed Dr. Linda Bluestein on my podcast a few weeks ago, and she has, dedicated a lot of her, really her entire practice to that. And so reaching out to people like that who have kind of global platforms and resources makes it a little bit easier. And you can also visit the EDS website to find practitioners who are going to be literate in hypermobility and not just throw some general exercise at you or throw a diagnosis at you and say, okay, you have EDS. Good luck with that. There's a
Yeah.
lot more that can be done.
I find a lot of, is my experience too with endometriosis, before getting a surgical diagnosis with an excision surgeon, a lot of gynecologists are like, yeah, you probably have endo, but like nothing you can do about it. It's
Right.
just,
Right. And I had a patient, it was probably 2 weeks ago. And this person is in healthcare, reach out and said, I saw my GYN and I have a family history. My sister had it, my aunt had it, et cetera. Highly likely that she has it. But my GYN said, oh, don't worry about it. You're getting ready to enter menopause anyway, and it's going to go away after that. Total false.
yeah.
Don't know if we can swear on the podcast, but oh my gosh,
You can.
that makes me want to swear. When people get, women get misinformation like that, like perimenopause and menopause, no, that's not going to change your endo. It's going to keep on keeping on wreaking havoc, in your system until it's actually addressed.
That's the most frustrating. I'm dealing with that with my mom right now because she has endo. She was diagnosed when I was born via C-section.
Oh,
Um,
wow.
and then never, no, the doctor was just like, you have endo. There's nothing you could do about it. You're lucky you got pregnant in the first place. Um, and then when I started having my issues, that like seeing her issues now as she's getting older has made me want to like, I don't want to be that. I want to deal with it now when I'm younger. And that's how I eventually found an excision surgeon. But yeah, I'm trying to, we go back and forth all the time because I'm like, you're not too old to get
That's right.
excision surgery or do pelvic floor therapy or different things to help. But every gyno that she goes to tells her that, you're in menopause and would it make sense for you to get surgery now?
Oh my
So
gosh.
frustrating.
Which tells you that really speaks to the level of just sheer ignorance about what endometriosis is. And I think that women have to start pushing back against the information they get, because how do they know whether or not it's misinformation? I hear too much misinformation surrounding women's health issues like endometriosis, like hormones, because there's no education on perimenopause and menopause or really endometriosis. In medical school and PT school and nursing school, no one is getting that education. And I can talk to the most well meaning colleagues that are also friends of mine and say, oh, well, your GI pain, oh, that has nothing to do. That's not a gyno issue, right? That's not a reproductive organ issue. Those are two separate things. And that is just flat out medical gaslighting. So I think, women have to start being more skeptical of the care that they're getting. Is this the care that I'm actually, deserve and that I'm due? That means you cannot look to your GYN or any healthcare provider. You can't look to them to be, kind of a gold standard for information. Fortunately, we do have the internet. And although a lot of docs out there will go, oh, don't be Dr. Google, I absolutely encourage people to Dr. Google it, chat
Yeah.
GPT it, whatever you want to do with it, and then bring it in and let's look at that together. What information have you found? Um, People will come in with all kinds of information, supplements, surgery, is this surgeon on the list? Are they a good excision surgeon, et cetera? And because there's so much a lack of education in our healthcare system, which doesn't seem like it's immediately changing, but there's some great programs out there that are trying to change it. Shannon Cohn and Below the Belt with her film and the education that they're doing now. I think it's in conjunction with um, Mayo, I believe, and with their school nurse education program. Things are changing. There's a lot of positives about it. But I think that if women would just question the advice they're getting and don't expect that you can go to your primary care provider or your GYN and have them be endo or hormone literate. I've had too many people, too many patients come in and they're getting information from their GYN that's over 20 years old
Yeah.
when it comes to endometriosis, and hormones, et cetera.
Just to echo what you said about being a Dr. Google, I met in my meeting other women with endo. It wasn't even endo necessarily related, but she was having really bad abdominal pain. Went to the ER. They ruled doesn't have an appendix from an endo surgery, so that's ruled out. And they kept saying they did a CT scan, everything was fine, and they're like, no, this has to be like there's might just be scar, whatever. Um, you're fine. Don't go home Googling things. You're fine. But
Oh,
she went on ChatGPT and like redid her own research, and it was all the things that she was looking up was saying you have all the symptoms of a twisted colon. So she went to a different ER, and just showed them like everything she looked up. And the doctor's like, okay, maybe you got a point. We'll do surgery. And it was a twisted colon.
oh my
And
gosh.
but the other ER is like, you're fine. I guess the CT scan, something she looked up to is that might not always show a twisted colon, depending on how. So, um, yeah, always be Dr. Google. You can't just go to one physician and take everything they say,
That's
especially
right.
when you're struggling
Mm-hmm.
and they're not giving you an answer. You can't just take their no answer and walk away.
Right. And then say, like that they had told her, oh, well, don't go home and look anything up. You're
Yeah.
fine. So then she goes home and what? Gaslights herself over her own real pain experience. And I think, unfortunately, that's the norm. That's what, and it's not just women, men and everyone can get gaslit. It just happens to be women are gaslit far more often when it comes to pain. And the statistics, and there's too many papers to even cite to support it. So for any skeptic who are like, no, women are treated equally in healthcare. No, they're not.
Yeah.
Just go look up the stats on it. They are there and it will blow your mind. Um, so yeah, you have to be your own advocate. And unfortunately, that's an exhausting, mentally taxing, emotionally damaging process to be your own advocate in a system that they should be the experts on how to help you with your pain. You shouldn't have to be your own expert, but unfortunately, you do. And I'm so glad in that case she actually pushed forward with that information and got help. I do often see um, adhesions and endo that cause the colon to turn on itself, to twist on itself, the bowel to actually get twisted and kinked, which is incredibly painful. Um, no one has to look very far on the internet to find my information and videos on YouTube to know that I had endometriosis, and I was one of those patients too that had the intestines twisted on itself. How painful is that? But no one is going to find that unless you persist, right? So that brings up an important point about that story too, is that if you are having severe random pain that you're walking along, you're fine, you eat something, and then a few hours later, as your stomach is starting to digest it and it's trying to go through that portion of it, you could have severe pain that's sudden, makes you break out into a sweat, makes you drop to your knees, that level of pain. And of course, that's what sent her to the ER, right? Is probably something like that, only to be ignored. Because when the pain goes away and the remnants of what's being digested moves through, it does resolve, and you're back up and you're fine, as if nothing happened. So if you're having that pain, you're listening, you're having those types of random pain, that would be a red flag to go get checked out.
That's good to note. That I'm happy you brought that up, that it could go away and then come back, and that doesn't mean you're fine. Just because
Exactly.
being in and
Yeah.
out, it doesn't have to be constant to be a problem.
Yeah, I think that's why a lot of people with endometriosis will also limit what they eat, or they'll eat the same thing, and then nutritionally, they're not getting the nutrients they need. They their body is not going to thrive that way. The immune system is going to struggle and be taxed. The gut microbiome will not have the diversity that it needs to be able to flourish, and then they have more issues like bacterial overgrowth or candida or whatever it may be, all because they've had to severely limit what they eat, when they eat, how they eat it, in order to just stand up and, like get through their whole day.
It could go on about that part forever. Kind
There's
of
a lot to
want to go
unpack.
back, want to go back to the menopause conversation, since we kind of brought that up,
Yeah.
um, and just specifically how the hormonal changes during perimenopause and menopause can affect both the hip and pelvic health.
Oh my gosh. Fantastically terrible ways. um, if we start with the hip, I find that a lot of women will have pain. It can be any orthopedic pain, but particularly in the hip, gluteal tendinopathies can be kind of common as well. What looks like a psoas tendonitis kind of thing, a groin pain, a pinching in the groin, can all be related to these cyclical, um, you know, kind of patterns. And that part of the cycle is typically, if you're still cycling or if it's irregular, it's going to be sometime during ovulation or around late luteal phase. So just before you start your period. That's when pain can surge quite a bit. And then we have to step back from that and go, okay, what is that? What's happening? First, I want to make sure there's no hypermobility. If there's hypermobility, you do experience an increase in laxity, especially with the surging estrogen. And we want to make sure that estrogen is metabolized well, and that B, as estrogen is surging, during those times, or declining as progesterone's getting ready to come up, as you start your period, that those levels are actually manageable. And it's not so much the levels, it's what your body's doing with it. How's your liver metabolizing things? This is very related to pelvic health. Is there constipation? Still, that goes with endometriosis too, which can happen during the cycle. Sometimes pain will get worse during the period. Sometimes it gets a little bit better, as the cycle starts. So that's where you want to look at those hormones and say, okay, what's the body doing with those? Because estrogen is going to be excreted, it's metabolized and then excreted through the bowel and the bladder. And if someone is constipated because maybe the bowel's twisted on itself, or maybe they have endo lesions on the bowel and they don't know it, well, that's a recipe for disaster with constipation. And then the estrogen is not metabolized, it's sent back into the system. And then you can have something called estrogen dominance, is kind of I don't know, it's not a controversial word, but it's not a great descriptor for, what it is. However, because it doesn't mean you necessarily have too much estrogen, because as you go through menopause, women, people are like, well, wait a second, estrogen goes down. How can you have too much estrogen, right? And it's just a simple way of describing how your body's metabolizing the estrogen. If your body's not metabolizing it well, that's where it will appear that you have too much, and you'll have estrogen dominant symptoms. So heavier periods, longer periods, more breast tenderness, more bloating, more constipation, all the things. And then as you go into menopause, perimenopause, and menopause, more hot flashes, more night sweats, more mood swings, all of that is part of that kind of dominant situation.
Yeah.
So you can put hip and endo pain kind of in the same bucket here when it comes to hormonal issues, because if the body's not handling the level of hormones that it has well, and you have other gut issues related to it, you kind of have a perfect storm for more pain. And more systemic inflammation can come along with that. So then how do you handle that? Well, we go back to the lifestyle medicine that we first started to talk about. And that's why I think that when you practice integratively, and that's a large part of what I do as a pelvic and orthopedic PT, is I also practice integratively. I want to use integrative and lifestyle medicine to be able to help women with nutrition, sleep, physical activity, environmental contributors, the things we mentioned to earlier. I mentioned earlier, and then the stress management piece. All of those pillars, okay, there's 6 total. The stress management breaks out into social interaction, which makes it like a 6th pillar of lifestyle medicine. But you can use yoga as well, forms of meditation, mind body therapies, cognitive behavioral therapy. There are certain plant-based choices that you can make and include into your diet that would help improve estrogen metabolism. That would, tamp down on the estrogen dominance. That immediately improves the bad period symptoms. It also improves the perimenopausal symptoms. It also cuts down on the hip pain. The only thing that would be left out of that kind of big bucket that we just discussed would be hypermobility. If it's hypermobility, I have to circle back and I use imaging to then take my measurements in the clinic and say, okay, we have to create a very sturdy pelvic girdle that is hypermobile. Maybe because they have hip dysplasia or they could have endometriosis. The two are like very closely intertwined. Regardless of which one it is, of course, if it's endo, then hopefully we have taken care of that with excision surgery. But if it's hypermobility, then you're still left with managing that. And so that's how I go about, handling the hormone bucket of the hip pain and the endo issue, especially as women go into perimenopause and menopause. It is not going to change. It could actually get worse. If you think about estrogen dominance and the body not metabolizing it well, what are the endo lesions going to do with that, right? Is that going to help or is it going to make it worse? And as you lose estrogen, if that's not well managed, estrogen is your inflammation mitigator. So when you lose estrogen, inflammation goes, unchecked. And so we work and use, integrative and lifestyle medicine to bring all that stuff down.
Are there any special considerations specifically for endometriosis patients as they enter perimenopause that you recommend?
Yeah, definitely. I think that should be like a specialty area of care. It's certainly an area of care that I've kind of set myself up into specialize in as a PT, but I think we need people recognizing that it's a specialty kind of time of life, that if you have endometriosis, you really need to lean in to integrative care, lifestyle medicine. Pelvic PTs can do it. Um, Other practitioners would be less suited, I think, to do it because, like, if it was a nurse practitioner, they could certainly do hormone health, but then they wouldn't have the pelvic health side. So you kind of want to have both when you're doing that. A GYN can certainly be aware of integrative and lifestyle medicine existing, but those practitioners usually don't have the luxury of time. And if they're still delivering babies, they're not specializing in menopause, perimenopause, or endometriosis. And so they just don't have that skill set to be able to treat it. But when it comes to that, I think that measuring what's going on, so screening, I have a perimenopause, menopause screen. How many of those signs and symptoms do you have? If you're checking a bunch of boxes, well, of course, we got more work to do to be able to intervene. But because whatever symptoms you had experienced with either endo pain or hip pain or what other kind of orthopedic pain you have or GI pain, usually will get worse during perimenopause, not better. So that's the time to really start measuring what's going on, with levels, metabolism, making sure that inflammation is being mitigated, making sure you have the best gut microbiome possible, making sure that you have good immunomodulation or immune system functioning, and then that last piece of stress management. And that's in addition to the stuff that I would tackle in pelvic PT, like, a non-relaxing pelvic floor, right? Or a hip pain or a tendinosis that also has to be taken care of.
A long list of things to keep track of. It's like a full-time job having all these
Yeah,
issues.
it is. It is. I have a little YouTube video. Maybe we can put it in the show notes of what
Yeah.
endo care should look like. And I have 5 or so pillars of care. And it's kind of what I just listed out, but it's kind of nice to see it written on the whiteboard. Like, if your therapist is not including all these aspects, then, reach out. I do a limited number of free consults, or I know a lot of therapists across the country. I can, refer you to a colleague nearby so that you can get the care that you need. But if you don't have all those pillars of care, then you're not getting the care you deserve.
Super important. The amount of specialists out there that are not really specialists and just market themselves as such.
Right. It does happen. It does happen a lot. And I think one of the most important things that we can have as a provider is humility, to realize that we can't treat it all. We cannot do it all. If I am hanging my shingle out and I say, I'm specializing in, endometriosis, as a physical therapist, and hypermobility disorders, which includes hip dysplasia, et cetera, then I have to know my limitations. I have to know when I need to refer. I need to know when that may be a surgical referral, a lab referral, any other diagnostic testing that may be done, because it really does take a village to be able to treat endometriosis as a whole body, disease and process that it is. So I think that's the most important thing to look for in your healthcare provider. If they don't say a version of what I just said, that everyone has a limit and you should know exactly who to refer to, and you should know that if you are not up on the latest evidence, that you can ask someone who is, I think that's a red flag,
Yeah.
because they're telling you, oh no, like we just were talking about with the case, there's nothing wrong with you, don't Dr. Google it, or it's just menopause, it's going to go away. No, definitely not. If you feel like you're being medically gaslit, you are. If someone feels like they're coming at you with ego, like, oh, I know better than you how you feel, go home and don't worry about it, it's all in your head. Yeah, that's a red flag. Trust yourself, and don't take anything else. Don't take no for an answer, if you're still hurting, because that's not fair.
Thank you for this whole conversation, that whole journey from pelvic floor function to hip pain to hormonal changes, especially in the context of endometriosis, perimenopause, menopause. Thank you for all your insights. And before we wrap up, I just want to let our listeners know that they can connect with you on Instagram at Dr. Ginger Garner. It's GingerGarner.
NER.
Sorry.
Yep.
I'm like reading them. And learn more about your practice and resources at garnerpelvichealth.com. Um,
Yes.
Thank you, everybody, for listening for this important conversation. We've hoped you've gained valuable insights to support your healthcare journey. And until next time, take care of your amazing bodies.
Thanks so much for having me.